Come back to talk to us about drug and alcohol abuse in working with the older adults.
Very quickly, how do you feel about Kate?
So we're going to let her start her presentation.
Okay.
These are our three new members for Legacy Corps who are just starting. This is their absolutely first day in the training. So anyhow, welcome, Linda.
Thank you for having me here this afternoon. And thank you to the Legacy Corps volunteers for participating in this program and for being willing to give of your time and yourselves. And we are going to be talking about substance abuse. We're going to be talking about drug and alcohol use kind of on a continuum. We're also going to be talking about what makes addiction addiction. And if you have any questions about what addiction means or working with that, with the small groups, we'll have plenty of time to have a lot of interaction. I invite questions, let's have discussion, and I do have a copy of the PowerPoint, so I'm sorry.
Well, that was good.
Throw it at you.
You've done this before.
So as you pass out the PowerPoint, maybe if any of you could just tell me a little bit, any experience with addiction or substance use, maybe working in, okay.
My father and my stepfather were both alcoholics.
Okay.
I've been to a couple of Al-Anon meetings. A very good friend of mine was a drug addict.
Okay.
So, yeah, I mean, I know what it's like to live in that kind of environment.
And thank you for being so candid about that, because I think, you know, when we are living in a system that is permeated by the dynamics of addiction, it affects everybody. In fact, in Al-Anon, you maybe have heard this, they have a saying that when there's an alcoholic in the family, it's like the whole family had the same operation, but the alcoholic got the anesthetic. You know, if you think about that, what that means is that everybody kind of organizes around the insanity, everybody kind of organizes around the pain, everybody feels it, but it's the active substance user that sort of gets to numb out and detach from the chaos that they may even be creating. But everybody learns to participate in that system. And so there's actually some parallel dynamics that we see in family members that we may be talking about as well.
The hardest lesson I had to learn was can't fix it.
Can't fix it. And in fact, in alcoholic families, that kind of culture of caretaking and wanting to fix and wanting to rescue, and you would think you would just be able to love them well. And maybe if you just do everything right, or you're a good enough kid, or you get high enough grades, or you make sure that everything's calm, then maybe they'll love you enough to stop. Or maybe you can say the right thing. And that's absolutely one thing that Alan, I get the 3 C's. You didn't cause it, you can't cure it, you can't control it. And a lot of times, especially children in alcoholic families, really kind of grow up with that idea that, you know, if they just do everything right, somehow they might be able to temper. If I did, maybe Dad will drink a little bit less if I do this or do that. And it really has nothing to do with that. And we're going to talk about how that relationship with alcohol or other substances develops for the person who's using. We're going to spend quite a bit of time on that. Okay, so, and again, I'm not trying to sell you on any particular mode of thinking. You know, a lot of times we call addiction a disease. Traditional treatment communities call addiction a disease. We'll talk a little bit about why it's considered that. If you've been to traditional 12-step groups or you have any familiarity with the 12-step program, you know, they call it a disease as well. They also call it an allergy, an obsession. So we'll talk a little bit about those kinds of things. But if any of that doesn't sit right with you, or you have questions about any of that, this is a great opportunity to speak up and have that conversation. Again, I'm not trying to sell you on a particular point of view, but to help create an understanding of why it's considered what it is by a lot of traditional modalities. Okay. And then, of course, we'll spend some time talking about how it affects older adults. A lot of words on this page, I know, but I just love this quote. Some of you might be familiar with Rabbi Tversky. He's done a lot of research in families and in addiction, and also a lot of work with how these dynamics permeate the Jewish community. I love this quote. It must be understood that chemical dependency, whether it involves alcohol, narcotics, cocaine, or other addictive substances, is a malignant condition. Unless arrested, it's like a cancer, progressive, destructive, and lethal. It may claim as its victims not only the user, but the family members as well. Its consequences are far-reaching and devastating. With a problem of this severity, we can no longer afford to deny or hide our need for help. I think that just conceptualizes the issue so beautifully, and then he follows it up with, I love this, the first step is awareness. As long as we believe the problem is not ours, we will do nothing. Okay? So before we actually get into the material, I want to challenge you for a second. I'm sure that if you've had volunteer experience in the past, or even some of your training here, you've probably had a lot of exposure to that idea of the need to be objective and the need to sort of put your own feelings and beliefs aside and to be present with the person, to be objective and non-judgmental. And that's great training and it's essential. However, we're also human beings. So I just wanted to challenge you for a second. And if you want to share out loud, that's fine. You don't have to. But when you see the sentence starters, working with an addict is, first thing that pops into your brain, gut, heart?
Difficult.
Difficult.
Challenging.
Challenging.
Emotional.
Emotional. There you go. Addicts always
Think they're right.
think they're right.
Put themselves first.
Put themselves first. Okay. Now again, you may have learned in your experience that you're going to be objective, that you're going to put some of these beliefs or judgments aside, but the fact is these are some of the things that come up, and they may also be the things that come up in the addicts we're working with that create shame and guilt. If that person believes that everybody thinks I'm a liar or a criminal or an idiot or a selfish, difficult person, then it might be a lot harder for me to tell you about what's going on because I don't want you to think that. So I just kind of wanted to expose you to how that kind of that uncensored sort of stuff still comes up. Whenever I have an addicted client, I
Cringe.
Cringe.
And again, thank you for being so honest, because even if we can put all that aside and work appropriately, this is sort of what prefaces that. Whenever I have an addicted client,
They don't think they have a problem.
I don't think they have a problem. We're going to talk a lot about how that shows up.
Are very manipulative.
Very manipulative. And how do you manage the manipulation? Exactly. Clients in recovery.
They're hard on the people that are still addicted.
So maybe there's even some judgment within the recovery/using community. Okay? If I hear that a client's in recovery, I
Want to help them keep sober or whatever their problem
Okay.
is.
want to help them with that. A lot of people with that will say, I'm afraid they're fragile. I don't want to do anything to make them go drink again. You know, and I think that's another thing we need to remember is while we can certainly support healthy recovery behavior, we're not powerful enough to make them go drink or blow their sobriety. It's not because we didn't say the right thing or that we said the wrong thing that they suddenly decided to throw away their recovery and go. Now, if they're really out there in the old thinking, and we'll talk about what that looks like, it may be that the manipulation enters and they can still blame you for it. If you hadn't done that, I wouldn't have. Doesn't mean that you caused it. They still made choices. It's very important. So just kind of wanted to put those sentence stems up there so you could sort of get in touch with how this issue touches us because it's activating. Most people have had experiences in their life with somebody who's been touched by chemical dependency at some level. And by the way, I've been using the words chemical dependency, addiction, substance abuse, and usually when we use those terms, we're talking about ingestible things, cocaine, alcohol, prescription drugs. But we can also see the same kind of addictive behavior in what we call process addictions, which would be the behavioral things. The gambling, overspending, overeating, undereating, exercising compulsively, spending compulsively. They create very similar chemical reactions in the brain. So when I say addiction or chemical dependency or substance abuse, I'm certainly not leaving out those behavioral things also. They can create some of the same.
Is codependency considered an addiction?
You know, that's been a question for a long time, and I'm glad you bring that up because it's kind of interesting. Some of you probably heard the word codependency to refer to essentially a constellation of compulsive caretaking, rescuing, enabling behavior that often comes up in families that live with alcoholics or addicts. And in fact, when the word was first developed, I think it was in around the early 80s when we started really looking at dynamics in alcoholic families, researchers started recognizing that, okay, the alcoholic has all of these behaviors, but the people that live with them are starting to develop some behaviors that look sort of compulsive and addictive as well. And that's sort of where the word came from, the co to the dependent, the codependent. But as the research broadened, they really found that anybody who has been in relationships with people that are alcoholic, addict, or otherwise emotionally unavailable can sometimes develop these codependent characteristics, which has been sometimes called an addiction to somebody else's dysfunctional behavior. It does trigger some of the codependent behavior, the rescuing behavior can trigger some of the same chemical reactions. Like if I need to rescue you and I need to fix you and I do something wonderful and you give me all kinds of good validation, then I get some kind of a rush from being able to fix. So in a sense, it is like a behavioral addiction, although we wouldn't necessarily look at the physical manifestations in the same way.
I think it's the compulsivity.
It's essentially a compulsive need to be needed. Codependency can almost be, like I said, it was for a long time kind of defined as an addiction to somebody else's addiction. Often the codependent person is somebody who can't go inside of themselves to find some sort of internal self-worth or value or purpose. I can't go inside to do any of that internal validation, but everything is outer focused. Everything's an outer reach for inner security. So in other words, I can't validate myself, but if I can come into your life and pay your bills, clean your house, raise your children, fix your life, then you'll need me and you won't go away. So it's like a compulsive need to be needed. And on the surface, if we were to look at codependency, it would kind of look like, well, rules for being a nice person. You know, what's wrong with putting your needs before mine? What's wrong with worrying about what you want before I worry about what I want? And of course, in relationships, that's always going to happen sometimes. When somebody we care about is in crisis, we may put our needs on hold for a time and be there for that person. But the healthy belief would be, and then when we're in crisis or have a need, somebody would be there for us. What a codependent tends to do is collect a whole bunch of people who are always needy and in crisis so that they can constantly kind of be doing that rescuing behavior. But when they have a need, there's no one there because they've surrounded themselves with emotionally unavailable people. Does that make any sense? Okay. So the boundaries become very distorted. Okay. So I think, yes, absolutely. Codependent behavior certainly has compulsive or addictive qualities to it. It just doesn't manifest itself the same way physiologically. But I certainly think about it as an addictive process. Okay. Other questions about that stuff so far? Okay. So just to go a little farther with how we look at addiction, a couple of different ways that it's defined. Society essentially for a long time, we're starting to have a broader understanding now, but it's considered a moral failing or a weakness or a bad habit. For a while it was even considered an insanity where people would be put in asylums. The medical and treatment community thinks of it as a disease. Looks at the criteria of it being physical, chronic, progressive, and fatal, and primary, and considers it a disease. And then the 12-step fellowship, I love this line, it calls it an allergy of the body with an obsession of the mind. And if you think about an allergy of the body, essentially just being an abnormal reaction, an allergy is an abnormal reaction. We're going to talk about this a little bit more. But somebody that has the condition of addiction is going to react to the substance or the stimulus differently than somebody that doesn't have that condition. They react to it differently emotionally, physically, and psychologically. And then an obsession of the mind. If you talk to any good addict, they'll talk about the relationship, the best friend feeling, the constant preoccupation. Even if they're not using at the moment, they're thinking about using or planning their next use or coming off of their last use or having to cover up the stories because they used last time. So it really becomes a full-time obsessive job. So just some different ways of looking at it. Now, I wanted to talk about levels of substance use. I don't find this particularly useful to use with clients particularly because, of course, everybody just wants to be in recreational use. But just as a way to look at it, use could be any taking of any sort of psychoactive substance. And what psychoactive refers to is something that creates a mind and mood change. Something that changes us from our baseline and makes us feel different. So we could also say any taking of a psychoactive substance or participating in behavior compulsively so that we have a mind and mood change. Abuse would be the use continuing despite persistent or recurrent consequences that are often even made worse. This is somebody who's continuing to do behaviors even though they're starting to have consequences. And then dependence, what we call alcoholism or addiction, would be habitual compulsive use of a substance over a prolonged period of time. Now, a lot of our understanding now is that if somebody has actually moved into dependence, in other words, and we're going to talk about this in a minute too, their body is physically dependent on a substance in order to feel normal. They'll go into withdrawal if they don't have it. The understanding is that once they've moved into that phase, dependence, any introduction of mind and mood altering substances into their body will cause the process again. Which is why in groups like AA, you'll hear somebody say, I'm a recovering alcoholic, not I'm a recovered alcoholic. The belief is that even if they've been sober for 20 years, if they were to drink again, they would activate that process in their body again and be right back where they were very quickly. So, yeah.
Is a person an alcoholic and they've been sober for 8 years and they smoke some pot, would that trigger that same kind of reaction? Just cross drugs or whatever?
The science will show that anything that is mind and mood altering will do that. Now that doesn't mean that if somebody, I want to be careful with saying this because there's always exceptions. It doesn't mean that the first time somebody takes a Vicodin or is around somebody smoking a joint that they're suddenly going to go out and get drunk the next day. But for some people it can, because what it does is it triggers that thing in the brain that says 1 is too many and 1,000 is never enough. Most of you can probably relate to that idea of, like, say, if you're drinking. I've had 2 glasses of wine, I'm starting to feel it, I think I'll quit. I've hit my limit. And you walk away from it. You don't sit there and obsess that there's still a quarter of a glass left, you're done. You're done.
An alcoholic can't stop.
And they'll be preoccupied. I mean, you can almost see it show up in, like, if they're trying to have a conversation with you and their eyes keep, are you going to drink that? And so in other words, something physical is happening that's different. If you talk to the alcoholic or the addict, instead of instead of I'm starting to feel it, I think I'll quit, it's I'm starting to feel it, that's what I'm drinking for, give me more. It's almost like a switch flips in the brain and the obsession kicks in, which is why you'll hear so many compulsive drinkers when they go out into social situations and they'll say, I promise I won't do it this time, I'm just going to have 2 drinks, I won't let, you can keep my car keys, I won't let it happen again. And they may mean it. I mean, who wouldn't like to get a controlled buzz with no consequences? That'd be really cool. But the fact is that person, once they've ingested it, loses that ability to control. That mechanism that says I've hit my limit actually doesn't kick in. It doesn't exist. So that idea of any mind and mood altering substances, you're not going to tell the alcoholic that since they've never had a problem with heroin, they can't drink anymore, but it's okay to keep shooting up or to start shooting up. But it's an interesting discussion because that makes a lot of sense. Of course you wouldn't tell the alcoholic to start using heroin. That wouldn't make any sense. But a lot of heroin addicts in recovery say, I've never had a problem with wine. Why can't I drink? But I was talking to an addictionologist one time, as a psychiatrist that has a specialty in addiction. And I loved what he said. You can take this information for what it's worth and think about it. But he said, well, the only thing anybody really gets addicted to is dopamine and serotonin. Now, what he meant, he said dopamine and serotonin. Now, he was simplifying it. But what he meant by that is there's neurotransmitters in the brain that are responsible for our mood. Dopamine is one of the neurotransmitters in the brain that's responsible for feeling excited, for feeling up, for feeling that rush. When we do things that it's the chemical that's released if you're at a casino and get a big payoff. It's the chemical that's released during sex. It's the chemical that's released when we exercise, that runner's high, and there's other chemicals too, I'm merely oversimplifying, but that's a chemical that's responsible for feeling up. Serotonin is that chemical that naturally exists in the brain that's responsible for a feeling of well-being. It's that feeling you're going to get when you're cuddling, it's that feeling you're going to get when you're meditating, or it's that influx of chemicals in response to that feeling calm and relaxed. So what the psychiatrist was saying as he was joking is, well, the only thing anybody really gets addicted to is those neurotransmitters, because when somebody does cocaine, it's not just cocaine going to the brain. Cocaine opens the floodgates of dopamine receptors and dopamine neurotransmitters. So there's a flood of dopamine in the brain once you ingest cocaine, and that's why you get the rush. If you drink or smoke marijuana, there's an increase in serotonin in the brain. So you get that feeling of feeling good. But most of us, if you have a little bit of wine or something, you're going to have that little bit of a warm, fuzzy feeling, and then it's going to kind of go back to normal. The pendulum swings much differently in somebody who's an addict.
So if a person's drinking and they get a little buzz on, and that's it, is that the serotonin? Because you're just getting a little bit of a buzz?
And that's oversimplifying a little bit, but basically, yeah. Maybe another way to look at it, if this line here represented normal brain functioning, and this is just a metaphorical illustration here, but if this line represented normal brain functioning, and we do an activity or ingest a substance, we have a bump from the baseline. Maybe we're really relaxed, maybe we're really high, but or kind of have feeling a rush feeling, but it's an increase from the baseline. Now most of us, once that sort of wears off, the brain says, okay, let's get back to work and do our own thing here. But there's a little mechanism in the brain that says this is how much serotonin we're supposed to have, this is how much dopamine we're supposed to have, and when it thinks there's enough, it doesn't make any more. So what happens for somebody that's been doing this for a long time is instead of just going back to the baseline, they go a little bit below the baseline. And then the next time they drink or use, they've got to do some just to kind of get back up to normal, and even more to get the feeling they're looking for. Well, the problem with that is now their brain's had this long to think, I don't need to make any of those chemicals, because as long as you're ingesting them, I'm getting them synthetically. I don't need to do that work on my own. So when that rush wears off, come down a little bit farther below the baseline, they've got to use some to get normal, more to get high. But again, their brain's been on vacation longer, so they come down farther. And eventually it kind of starts to look like this. And this is why you'll hear some alcoholics or addicts say they had to drink in the morning just to feel normal, or just to stop the shakes. This is what the withdrawal looks like. So you're having to, after a while, you're having to use more substance than ever just to feel normal. And you may not even be getting high anymore, but you're having to use more substances than ever just to restore that feeling of normal. So what this essentially could be looked at as is a neurotransmitter deficit in the brain. Again, metaphorical, I'm simplifying, but does that make sense at all? Is it trying to, and so the addict will essentially have this obsession to avoid this and try to get here, or the illusion of recapturing this. You've probably also heard people say that it's never like the first high again, or that you can never capture your first high. Because when you first ingest a substance, it's brand new to your body. Your body's having this experience. And you may even be able to think about this if you start, the first time you started drinking. The first time you started drinking, maybe one beer or half a glass of wine really created a reaction. But after you've done it a while, your body sort of adjusts. And it can handle a whole beer, or it can handle a whole glass of wine without really having a lot of devastating effects. So essentially that's developing tolerance. Now in most people, you do that for a little while and you'll start to get a little perspiring. I'm talking about with alcohol, for example. Well, that's your body saying, okay, I recognize this is a toxin. I'm going to do everything I can to get rid of it. It's trying to get rid of it. You drink more, you throw up. Again, that's your body saying, I want to get rid of this. It's toxic. And if you drink past that, you pass out. Again, the body's really trying to protect you. This isn't good stuff. But you'll hear people that are chronic drinkers say, well, I could really hold my liquor. I can drink a whole 12-pack and not...
Because they always drink.
Because their body is so used to it.
It's like taking a new medication.
Yeah, that's another good example.
Because I know in the past, if I had surgery and I would take the medication, I said, oh my gosh.
Yeah.
I would always take a half.
Uh-huh.
Because I don't know how my body would react to it.
And if any of you have had the experience of maybe you've had surgery and you've had to be on something like Vicodin maybe for 2 or 3 weeks, you probably will notice, and it doesn't mean that you're an addict, but it does mean that your body is going through that process of tolerance. Yes. Meaning that maybe the day you came home from the hospital, half a pill was really effective. Right. But 2.5 weeks later, it's now taking a pill and a half. And again, it may mean that you can come right off of it and just feel, I'm not saying that there's not appropriate uses for it, but you are experiencing that physical phenomenon of tolerance developing. So what I would throw out there is if somebody says, I can drink a whole 12-pack and not even be stumbling, it's not that, wow, you can hold your liquor or that you don't have a problem, because you will hear a lot of people say that. I can drink 6 beers and not even be slurring. If you can drink that much alcohol and not show signs, that is your problem. Because essentially you're overriding the body's attempt to say, not a good idea. So does this make any sense here?
Or the running joke, I could read you under the table.
Yeah, I'll be under the table.
I was watching Dr. Phil last night, and it was about an intervention. And this kid was 28 years old. They had the whole family there, and there's this mother-son team. He used to be addicted to, I think it was either coke or meth, and he's now a part of helping people recover. This guy's on the show was 2.8 was his alcohol content.
Wow.
And he was shaking, and he says he has to, just exactly what you were saying, he says he has to take a little sips of vodka, and they lined up what he drinks in a month of vodka, and it was like liters, 90 liters of vodka a month.
Gosh.
Sounds deadly.
On the bathroom.
Unbelievable. So he went into recovery at the end of the show.
Wow. And thank you for sharing that. I'm jumping ahead a little bit, but just since you mentioned interventions. When an intervention is done correctly, and there's been so much television shows and things like that around interventions, it's been a little sensationalized. When an intervention, when we think about it in the clinical sense of an intervention, is done correctly, probably like what you saw, there's somebody who's trained in doing interventions that meets with the family and creates a scenario, probably or prearranges a treatment center, and then when the intervention actually happens, it's not really, let's all attack him and make him go. It's supposed to be really done like a gift of love. And also a way for the family members, probably usually not the first intervention, or the first effort that is made, the first attempt. Usually other things have happened and not worked, and this is kind of a family's last effort so that they can say, we know we've done everything we can, and we're not going to sit by and watch you kill yourself anymore. So here's this gift we're going to give you. We're going to tell you how important you are to us. We're going to tell you how much you mean to us. We're going to tell you how much your addict behavior is affecting us. We're going to give you an opportunity to do something about it. And if not, here's what's going to happen. And that the family is well prepared ahead of time about what they're going to say, that it may even be a little bit scripted, and then the interventionist would be present so that it doesn't deteriorate into accusations and a fight, and that's really not the point. It's supposed to essentially be a gift of love. And when it's done correctly, it can be very effective. But the reason I'm bringing it up for you right now is because if you're in a situation with a client and you're approached by a family member that wants you to help them do an intervention, or you've seen an intervention on TV and you say, I can do that, to just remember that usually it's a very, very choreographed, planned effort that involves a lot of people and a lot of forethought. And an intervention in the clinical sense is not a bunch of people ganging up on the alcoholic to tell him you better go to treatment or else.
When we tell them to deal with their social worker for that, we wouldn't have to
Absolutely.
take that on.
Absolutely.
Right.
You would take, and I would even suggest that the social worker doesn't necessarily jump right in the middle of it and try to choreograph an intervention. Maybe we can make referrals to people
But it's
that are
not our
trained to do that.
responsibility.
Absolutely, no,
Okay.
and that was the whole reason I wanted to go there, is because you may be approached by a family member or a caregiver that's, that saw that Dr. Phil episode and wants to do that, and doesn't really get how really intricate a proper intervention can be. So I know I got a little off track there, but I just wanted to kind of use that as an opportunity to say, don't put yourself in that situation.
Okay.
You absolutely don't need to.
Okay.
In fact, the best thing you can do would be to help with referrals.
I was gonna say that, I know they were saying earlier that we'll take notes on certain things, so that'll be something that we'll pass it on.
Give it the info to the social worker.
Sure. Hearing that you're interested in having a formal intervention done, your social worker can help you discuss some options. Yeah,
Okay.
absolutely. Because that is, and it looks like such a good idea. Everybody's going to put all of this energy into making the addict change. Well, as you just said, we can't control it. We can't
They
change
have to
it.
want to change.
Yeah, and if they're not willing to listen, then it could be.
Right. which is where the art form of a formal intervention comes in, because it's so key to create a situation that when the person walks in and sees all of their loved ones and their boss and their clergy person sitting right there in their living room, that they're not already going to take off. The art form is right there in the beginning of how do we even get you to stay to hear what we have to say. And that can go wrong so easily that you really don't want to put yourself in that position.
Okay.
So, absolutely. So, now helping a family member access the person that can help them with that.
That's fine.
Absolutely. Okay. So, since we've been talking about this, I want to talk about some of the multifacets of addiction. And we were talking a little bit about the physical already, the physiological differences, that obsession that kicks in when somebody ingests a mind-altering substance. Science is also finding that there is a genetic predisposition. What that means is that if you have parents or grandparents that had the disease, and when I say the disease, I mean the physiological piece of, not just they drank a lot, but they actually have that chemical dependency we've been talking about, that it's more likely that you will have that. And what I mean by that is, some people can drink for 10 or 15 years before they start to develop that dependence we were talking about. They can drink for a really long time. I've talked to other people that say, I had my first beer at 15 years old, and that's what I was looking for my whole life. I was put together from that first time I ingested whatever. That's what my body just knew. And so you can tell and that's certainly not the case all the time, but there is an indication that there can be that genetic piece. And then, of course, we've talked about tolerance and dependency. One of the things you'll hear about addiction is that it's primary. And what primary means is that it came from itself, basically. You can't become chemically addicted to cocaine if you have never ingested cocaine in your life. You may have every genetic and psychological predisposition, but your body can't become dependent on a chemical it's never seen. However, when we talk about the genetics, just a story I'm thinking about a girl I was working with who was probably in her mid-20s, alcoholic mom. Mom was still drinking to that day. She grew up in that very chaotic alcoholic household and hated alcohol, absolutely despised alcohol. She told me she had never had a drink in her life. I have no reason not to believe her. She hated alcohol. She says she doesn't drink. However, by the time she was 16, she was eating compulsively, purging compulsively, taking laxatives, and addicted to sugar. So
she used one for another.
Right. And what we understand now about refined sugar, too, is that it breaks down in the body very similar to the way alcohol does. So was she alcoholic? No. Had she chosen alcohol as her mind and mood altering process of choice as opposed to sugar, she probably would have become alcoholic. Was she still an addict? Absolutely. So you can see kind of that there's certainly that genetic predisposition. She just didn't choose the same drug to use. I wanted to spend some time on this one because I think this is probably one of the most interesting but most frustrating characteristics of addiction, and that's the psychological piece. Now, when I say that, it may be that perception is distorted, time, responsibility, there may even be some cognitive impairment, the thinking isn't really clear, and you would kind of expect all of that if you're doing something that affects the mind and the brain. But there's also this web of defenses that a good addict will get very practiced at using, and I wanted to explore those because certainly you're going to encounter them if you're working with a client who's actively using substances. And these defenses are mechanisms that the person has created not just to protect their using from the world necessarily, but also so that they can get okay with it themselves. Because at some core level, they may know they're not making the best choices, but in order to continue to participate in this relationship, they've got to make it okay somehow. So the defenses may simply look like denying it's not a problem. In AA, they have a saying that denial, D-E-N-I-A-L, stands for don't even know I am lying. About that. You get so good at telling the stories that after a while, you start to, or especially your mind's a little bit altered with substances, it's real easy to start to believe a story that isn't true. Minimizing. What minimizing refers to is indicating that it's less of an issue somehow than it is. But that can come out in a lot of ways. It's not just like saying, I only drink on the weekends, although that may be one way it shows up. When we're asking questions or looking for information or doing an assessment, we have to really pay attention to what we're doing with the information we're given and how we're asking the questions. Because, for example, if we say, how many drinks do you drink in a typical day? And they say 2. And we go, 2, I've had 2 drinks. Not a big deal. Well, did we ask how big the glasses are? Because maybe they're, I talked about
but if they drink 2 a day, let's say, not just on occasion.
Right. It could still be compulsive patterns. Right. But I wanted to just draw attention to that idea of that person saying, well, I have 2 40s, but if they said 2 drinks, are they lying to you? Not technically, it's 2 drinks.
Do you all remember Sammy Davis?
Yeah.
He was on the Johnny Carson show one time. He was trying to give up smoking, and he put out a cigarette with a slog.
But 1 a day. Yeah, right. Exactly. I was talking to a guy one time and said, it's 1 drink till I put the bottle down. So that's how they define it in their own mind. So that ability to minimize or to rationalize. Okay, I only drink on the weekends, but if it's a 3-day weekend, can I drink until Monday night and still not be breaking my rule? If I'm too hungover to go to work on Monday, is it still part of my weekend? Okay, so that justifying and rationalizing. This also comes out not just around the using, But you'll see the addict or alcoholic kind of personality use these almost in everything they do. That ability to blame and externalize and not take responsibility. And I know I'm stereotyping here, I'm just bringing out some characteristic features. But that ability to justify and rationalize. I only got a DUI because the cop needed to meet his quota. If my wife wasn't such a nag, I wouldn't need to really, to shut her out. If my boss wasn't such a jerk, I wouldn't need to unwind at the end of the day. That constant ability to externalize and then to blame. And some of the ways that you see this come out are, and some of the incredible stories that you might hear that when you hear them sober can actually seem ridiculous and maybe even a little bit humorous, which is why actually if you've ever been to an AA meeting, there's a lot of laughter. Because when you look at the stories sober, they really don't make a lot of sense, but they speak really well to how much the addictive process can change the way we think. For example, I was working with a guy one time and we were doing a group and we were talking about rules you make for yourself when you're out there in the active stages of the behavior and how those rules start to change over time as it progresses. And he said he had this rule, and this, again, he was sober, it sounds totally absurd, but this is what he was selling to himself. He said he had this rule that he would never drink and drive. Never drink and drive. But he got to the point where he could stop at a red light and take a drink.
Oh.
Okay, I'm not officially driving, I've stopped. He wasn't telling the world that. He was selling that to himself. I'm not breaking my rule because
I'm at a red light.
I'm at a red light, I'm not drinking and driving, the car's not in forward motion. That was how he held on to that rule. Never broken that rule. I'm working with another girl, she was a methamphetamine addict, and she kind of had this idea in her head, because a lot of times they'll say, people say, well, I'm not an alcoholic because I never drink more than 2. I'm not an alcoholic because I only drink on the weekends, or I never drink hard liquor, or whatever rationalization that they hold in their head about what an addict or an alcoholic is. Her idea was an addict is somebody that used money they needed for essentials on their drug. So if she used money she really needed, then she was an addict. But she said, some people go out to dinner and go to the movies with their discretionary funds. If I want to buy a couple of lines of meth for a fun time, what's the big deal? Okay, so that was kind of her idea. But if any of you know anything about methamphetamine, one of the first things that happens is you lose your appetite. So she was very quickly able to say, well, I don't need to buy food as long as I have meth. But she's hanging on to that rule. Food's not essential, so I'm not using money I need on essentials. So she just moved that line over. And she says she finally got into treatment, and no kidding, what she said is I was walking down the street saying, well, who needs to pay rent when you're homeless? So think about how deeply that permeated. This is not happening for the world. She wasn't trying to sell this to the world. This is what she was doing with herself. I'm not an addict because I'm not using money I need on essentials. I don't need to eat. I don't need to pay rent. I just need my meth.
But you know what it all seems to come down to? Justified.
And so
everything there is justified.
Right. And so if you think about that, and the reason I wanted to kind of discuss this a little bit is because a lot of times this is so subtle. I'm giving you some examples that seem really ridiculous. But a lot of times it's so subtle that you may think, well, maybe I'm being too hard on them. Maybe I really am being judgmental. Maybe I'm the crazy one. Maybe I'm, and because it's so easy to think, well, yeah, that story really makes sense. I guess so just if those bells are going off inside of you, it doesn't necessarily mean they're lying to you or doing one of these things, but it's definitely, if that's going off inside of you, pay attention and see what it's trying to tell you. Because again, that manipulating. So yeah, so these defenses, and again, they can be fascinating when you look at them kind of removed, when you're trying to live with one or help one. It can be very, very frustrating. Questions or thoughts about any of this? Okay.
But when we first meet somebody, we may not notice.
You probably won't notice.
Right, we probably won't notice that, let's say they took some pain pills, for instance, because that's, and then we see them again and they took the pain pills. Alcohol you can smell.
Right. No, absolutely. It may take a while to know what the baseline is.
Okay.
Or you may never see them not at that sedated baseline. So that does seem, and that might be where, collateral information from family members is helpful. It may be that you might start to notice inconsistencies. That the story they told you about something from one time to the next, even though they seem like they're behaving the same, maybe there's memory gaps that can't really be explained by age, or there's some inconsistencies that they've started to misplace things, or they seem to be a little bit confused, or they're not tracking the conversation as clearly from.
But I imagine they will be seniors, so they may have some other problems, dementia or Alzheimer's or
It's
something.
true, I mean, most of our clients are older adults, and they may have sort of the beginning stages of some sort of dementia.
So we may not recognize it as a substance abuse as opposed to.
If they were doing something, right.
And the family members may not either. And I think that's
No,
one of the.
because they're so close with them, they don't notice the change.
And there's so many parallels to intoxication and some of these other things that we're talking about.
Okay.
You know, and a lot of times too, things, even behavioral things. You know, if grandma falls, you know, a lot of times people think, well, osteoporosis or hip, you know, we say now, a lot of times the bone breaks before the fall and that's what causes the fall. The hip broke, she fell. Maybe we're not thinking, well, yeah, grandma fell because she was smashed. You know, I mean, we're not thinking like that necessarily. So
Right.
a lot of the things can be explained. So again, I think it's, yes, often what you're seeing may not be chemical dependency, it may be signs of aging, it may be early signs of dementia, but if those bells are going off inside of you at some
You have
level,
a
you're
gut
noticing
feeling.
those, it's worth talking to the social worker about, it's
Okay.
worth bringing up, and just because you may also be in a position to be noticing things that somebody closer may not be, like family members, so, yeah.
And one of the things that I read about too with like alcohol and drug stuff too is that like it's not the same word as dementia, but it can lead to like, you know, obviously like their brain is like they forget stuff too because of all the years of use. Yeah.
Yeah, actually, it's a very good point because, again, it gets so much harder to discriminate. Sometimes active intoxication can look like these symptoms, but if somebody has been drinking for a really long time, and it's different for everybody, but there is actually, you've probably heard of it, it's called organic brain syndrome or wet brain drunk, you know, where the alcohol has permeated the brain cells to such an extent that cognitive deterioration is actually progressive. And it does look a lot like Alzheimer's or something, even though it's alcohol-induced.
Or like the dry drunk, like they stop drinking but they don't go to meetings or they don't do anything and they still, even though they're not drinking, they still have the behaviors because they haven't worked on themselves to, you know, like with AA, they have all the steps to work through, and they just because they stop drinking, they still have those behaviors.
Right.
So.
Right, and I love that you use that phrase, AA calls it a dry drunk, and I love that phrase because when we think about recovery, you know, it would be easy to think, well, we'll stop here at the physical part. You know, if you're in recovery because you're not ingesting the substance that creates the mind and the mood alteration anymore. But what we understand about this entire condition that is psychological and emotional as well is that if the only thing you do is stop ingesting, just like you said, but you're still doing everything else the same, it's a pretty miserable way to stay sober. And it's not comfortable for the people around them either. So in recovery, that's one of the reasons why traditional treatment programs don't just say abstinence and then that's over. In fact, they say in AA that abstinence isn't equal to recovery. Abstinence is a prerequisite to recovery. Because you get clean and sober, you get chemically free, and then you're emotionally able to work on the other deficits or as Gilliam calls it, character defects.
Makes
Right.
sense, but I guess that's why they say that basically you shouldn't go into therapy for the first year of sobriety. It's because you're not really dealing emotionally with the real stuff.
And now that was a long-standing kind of belief. I think
Isn't that true now?
well, it really depends on your school of thought. A lot of people, it kind of goes back to the you can't control it. A lot of times therapists didn't want to treat people in the first year because they didn't want to bring up issues that would make them go back out and drink. Now, I don't know that any therapist is powerful enough to make them go drink. However, it would be just like anything else. You may not want to go to the deepest psychological wounds if they don't have any tools to deal with everyday hurts. So I think the foundation needs to be built. What we are starting to understand is that therapy can be a very good tool for building a foundation of coping skills. And once you have that in place, then you can go, you know, into, but I think, yeah, that traditional, let's go back and deal with your very deepest trauma, you know, when you're 2 days clean. You know? For a lot of us, it's partly because of the vulnerability, but how much good would it really do if the person doesn't have the ability to process it anyway? You know, on the other hand, if they're still drinking and you're trying to do great therapy, you know, that's really tough too, because even if the person isn't intoxicated in session, if stuff comes up and then the only way they know to deal with it is to go get loaded as soon as they leave, it's like the process stops. Which brings us to this next part, which is that it's also an emotional condition. And what that means is that emotions may be numbed, emotions may be exaggerated. Chances are the person doesn't even really have a feeling vocabulary. I remember talking to a guy one time, he said when he got clean, he had two feelings, bad and not so bad. I said, just when I was talking to a guy that when he was getting clean, he said his two feelings were bad and not so bad. but to have that whole range of feeling vocabulary to understand the nuances of an emotional condition. It's just not built in. And then coping skills will be impaired. Have any of you ever heard that when you start drinking or using, your social and emotional development stops? Kind of heard that said. And basically a way to think about that is, as we all go through life, we have certain milestones that we go through that give us feedback about our behavior. Like, for example, we have our first crush and our first heartbreak, and we learn something about relationships. Wow, I'm never going to do that again. That really hurt. That part really worked well. We get our first promotion. Wow, that feels good. That's how I'm going to behave professionally. Our emotions give us feedback that condition our behavior. Well, imagine you went through all of those emotional milestones, but you were under the influence of a mind and mood altering substance, so you didn't really get the emotional feedback. You still created the narrative, but you didn't really get the emotional learning. I heard the analogy one time, it would be like putting your hand on a hot stove, but your brain didn't tell you it burned. You'd still do tissue damage, you'd still blister the skin, but you wouldn't really learn much about touching hot stoves because it's the ouch that says, I don't want to do that again. So if you think about it, somebody that starts drinking and using, say at 15, 16 years old, if any of you have ever worked with or tried to parent an adolescent, I'm going to ask you to be stereotypical here for a second. Stereotypical adolescent behavior, what would you see?
Defiant.
Defiant?
Rebellious.
Rebellious?
Invincible.
Invincible, yeah, that's not going to happen to me. Immortality.
Wise beyond their years.
Oh yeah, yeah, they know it all. There's a very kind of dramatic black and white sort of feeling. If I don't get that pair of jeans, I'll just die. You're the worst mother in the world. If he doesn't call me, my life is over. There's that kind of very dramatic quality. Okay, again, it might be difficult to try to parent that, but it's a pretty typical stage of development for an adolescent. But if you imagine that somebody started doing their mind and mood altering behavior at that stage of development, essentially they stop learning from those emotional milestones. They kind of arrest their development right at that place, which is why when you put all that together, a 40 or 50 or 60-year-old addict who's still been using can behave to the world very much like an adolescent. I mean, we've talked about justifying, rationalizing, blaming, denying, manipulating. So some of that can be very, very adolescent. You might be looking like you're dealing with your typical 15-year-old. The good news is if somebody really does get in recovery and start working on themselves, it's not going to take them 30 years to catch up. But you just know that and maybe kind of think about that too, that if you're feeling very frustrated when you're working with your client who's just seeming to be so adolescent, you know, it may be that they are, as far as the way their development
And
is.
just because they're sober does not mean that they're not still acting like an adolescent.
Right.
Because their brain might, even though they're sober and they're working on themselves, their brain might still be at that age.
Right. In fact, the AA has another saying. They say it's alcoholism, not alcoholism. And I love that because it really speaks to that. It's an ongoing condition. It may be in remission, but the addict in traditional recovery will say, I'm an alcoholic, not I was an alcoholic, because they're talking about that awareness, that ability for old behavior, that ability to think like their addict brain is always there, and the physiological vulnerability is always there, even if they're in remission. Yeah.
I dated a lady for a while who at the time we were dating was 6 years sober, alcohol and smoking dope. And so I asked her one time, do you ever think about, getting loaded? She's every day. 6 years later, every day.
And the difference for that, some people, it's even a line in the big book, which is the basic, they call it the big book, it's the basic text of Alcoholics Anonymous. They talk about freedom from the obsession. And some people think about it every day, sort of with some fond nostalgia, and it's never really a problem. Some people think about it and have to fight it every day. The serenity that the program talks about usually comes from what they call that freedom from the obsession, that they may think about it, but it's not a fight every day anymore. For some people it is, and that's a very difficult way to try to live. Which kind of brings us to this last point here, which is that it's a spiritual condition. And I wanted to bring that up because you will hear people use spiritual in connection with addiction and recovery. And for a lot of people that's really controversial, so I just wanted to spend a little time on it. A lot of times when we hear the word spiritual, we think religion or religious beliefs. And what I just wanted to challenge you to think about is that spiritual, meaning of the spirit, can mean something very different than that. If you think about what is our spirit, it's our ability to live, love, play, connect, have a personal value system that tells us what's right and wrong for us. There's a spirit. Now, for a lot of people, that is dictated through religious beliefs, and that's fine. But I just kind of want to draw that difference between religious and spiritual. And again, for some people, they're very integrated. They don't necessarily have to be. If you think about addiction creating essentially a disconnect from one's spirit, they might stop doing things they enjoy doing. They may stop spending time with people they care about. They may do things that violate their own value system. In other words, they've got a spiritual disease or a spiritual condition. And in recovery, we want to recover that spirit. And if they use a system of organized religion to do that, absolutely, that's fine. But for a lot of people that you might run into that say, I don't want to do that AA or that recovery thing because it's too religious. They do talk about it being spiritual. They do talk about a power greater than ourselves. But I've also heard, and I know this may be controversial too, but in AA, they say that GOD can stand for group of drunks.
I never heard that.
And the higher being can be anything that they want it to be. It doesn't have to be like God or anything. It could be a tree or whatever they believe in.
Right. Because walking into that room with this group and having every one of you help me not drink that day is going to be a power greater than trying to do it isolated in a bedroom someplace. So, whether it's nature, a tree, a group of people, a religious being, it's just that idea of, if everything we've said here so far, the addiction is very self-centered. The addict is very selfish and self-centered. So the spiritual recovery, the power greater than ourselves, is a way of connecting to the outside. So just to kind of diffuse any concerns that, oh no, I have to get religious if I want to get clean. There's a lot of different ways to look at that. And in fact, if you read the text of the 12 steps, the only part of the 12 steps that's underlined is where it says God as we understood him. And as we understood him is underlined, which really means, anything, any way you want to think about it. They also say that GOD stands for good orderly direction. That when I am spiritually recovering, I think in better and more orderly fashion than when I'm out there in the chaos. So again, however, I just wanted to touch on that because you will hear it. So, talk about these. We say that addiction is a cycle, and I always joke with my clients and say that's the real F word, feelings. What do you think some of the feelings that somebody might drink or use over might be?
Loneliness.
Loneliness?
Self-loathing.
Okay.
Sadness.
Guilt.
Sad, guilt,
Anger.
Oh,
fear,
yeah.
shame. Okay. So the addict brain will then have a thought. I know how to fix that fear, guilt, shame, anger, loneliness. And I can just have a couple of drinks or just do my behavior. Now, if you talk to somebody who's been doing this for a while, they'll say, I started thinking about it and I couldn't stop thinking about it. It's like it just became an obsession. The Vicodin was calling me from the medicine cabinet. I couldn't get my dealer's number out of my head. I couldn't stop thinking about it. Just had to do one to take the edge off. So they act out. Had all this uncomfortable feeling stuff. My brain told me I knew how to fix it. I couldn't stop thinking about it. So I act out. Okay, trick question. As soon as they act out, how do they feel?
What's that?
As soon as I said it's a trick question. As soon as they act out, how do they feel?
Relief.
Relief?
A short span of relief.
Short span of relief. Yeah, absolutely. It works. I'm saying works in quotes, but they feel better for a little while. Now, it may be, if the disease has progressed far enough, that it's not even really working, just like that chart we drew, it's not even really working. It may be the illusion of past relief that they're chasing. But either way, even if they get a little bit of relief, 20 minutes, an hour, 2 hours, now they're looking at their behavior. They've blown their paycheck, cheated on their wife, crashed their car, gotten a DUI, lost their job, whatever. How do you think they're feeling now?
Terrible.
Terrible. Shame, guilt, fear, loneliness, self-loathing.
And they drink to not have that feeling.
So you would think if you had a healthy thinking process in place, well, the last time I did that, it didn't turn out so well, so I'm never doing that again. Remember that impaired coping we were talking about. So what the addict brain is going to do is, wow, I'm so miserable, I'm so ashamed, I'm so lonely, I'm so
It's a
hateful.
circle.
I know how to fix that, I'll get loaded. And so pretty soon they're having to use just to deal with the feelings of using last time. Does that make sense? And again, I used the word relationship a little bit earlier, and I think it's really, in a sense, important to respect that for the addict or the alcoholic, this may be the most important relationship in their life. It may be the longest term relationship that they've had. Maybe they've had a relationship with alcohol longer than they've ever sustained a relationship with a human being. You may hear a lot of nevers in early recovery, like I'll never be able to hang out with my friends at that bar again, or I'll never be able to enjoy a wedding again, or, but again, it speaks to that relationship. And in healthy recovery, they will find that they can do those things some of those things in a healthy way. Okay, so we've already talked a little bit about some of the parallels, but I think this is an important concept too. Today's older adults might have very different attitudes about alcohol and drugs than in the past. Many baby boomers, for example, drugs might have always been present in their culture, maybe even in their life. We're no longer dealing with the 65-year-old who's never even seen a marijuana joint in their lifetime. We may be dealing with a 65-year-old who's a Woodstock. So very different attitudes, which might make the defenses even more difficult to permeate. Okay, we were just talking about this. Not all older adults are substance abusers, but many have medical problems that increase the potential for medication misuse. What we mean by that is, this is just an example, but think about medical conditions that might contribute to substance abuse. Let's say somebody's incontinent. Normal part of aging, goes with a different illness, but because of that they're embarrassed. And because of the embarrassment, they stop going out so much. And because of stop going out so much, they're feeling isolated. And because they're isolated, they're depressed. And they found that when they take a couple of Ativan or Xanax when they're depressed, it's not so difficult to be depressed. Okay. They may not have had any deliberate attempt to do mind and mood altering behavior. It may not have been recreational use. But you can see where a medical condition might increase the possibility of abusive behavior. Think about other things that tend to be chronic conditions or common conditions with older adults: anxiety or chronic worry, grief and loss, changes in identity or their role in life, loneliness, increased medical problems, insomnia. You'll see this a lot. The reason I wanted to kind of target these is because there's a number of prescription medications that can also cause, and I'm not telling you anything you don't know, chemical dependency. Not all medications work on that part of the brain that says some's good, more is better. They don't all create tolerance and dependence like we were discussing. But there are some categories of medications that do. Your typical antidepressants are not going to do that. Your typical mood stabilizers are not going to do that. However, painkillers, anti-anxiety medication, and sleeping medication tend to be in classes of drugs that create dependency. Well, when you think about a lot of the complaints that older adults might have, insomnia, grief, pain, emotional or physical, and so very often those older adults are appropriately prescribed, at least appropriate in the beginning, appropriately prescribed a medication to address that condition, but then inadvertently start to develop that dependency or the withdrawal if they don't have it. So you can see how easily that can happen. And then there's also the issue with older adults of maybe they've been like drinkers all of their life. They've had a couple of glasses of wine here and there and it's never been a problem. So some of it might be about educating your clients about how their body's changing may need to impact the way they look at some of these.
And it should say on the bottle, do not drink when taking this medication.
And have your clients been educated about it? Did the doctor go over that with them? Can they read the label? Is it too small? Maybe they've always done it and it's never been a problem, but now it's starting to be. So those might all be really good questions. Or you may see a client who really doesn't seem like they're drinking that much, but seems really impaired. Like they said they only had half a glass of wine, but they looked really loaded. Well, it could be that synergistic reaction of...
Their size of a glass is 16 ounces.
Exactly. See, you're asking the questions already. Or even if they did just have a smaller amount of alcohol, but they've mixed it with some of that other medication, you may be seeing a much different presentation than what that glass of wine would have done all by itself. So, something to think about there. This is all in your PowerPoint. I don't need to go through all of them, but these might be things that you see when you're visiting. And again, not that you need to do anything about it, but it might be good information to take back to whoever you're working with. And it could be the bloodshot eyes, the changes in eating habits. And again, these things, they're changes from a baseline, and it's going to take you a while to learn what that is. Poor hygiene or significant change in hygiene. And the reason we say significant change is maybe you're working with somebody that's never really taken very good care of themselves. So it may-
Sometimes they don't want to take a shower.
Which can be part of the depression.
On end. I mean, the social worker should know about that.
Right. And so again, that's where we're looking for a change. If they've been like that, it still may be a behavioral intervention we want to work with, or a treatment plan intervention we want to work with, but it doesn't necessarily mean that it's a sign of a behavior change.
Right. My friend has a problem with her mother right now with that. She won't take a shower. But that's another story.
I think the significant piece that you're bringing up there, though, is there's a history, there's a chronology, there's some awareness. It's not something that just started happening.
Right.
You know, and I think those are really good things to pay attention to. So again, some of these different things that you may observe. And they may say things like this that might, again, these are just those little alarms to go off that you just might want to report back that the doctor has me on so many medications.
They
now,
do.
Sometimes, yeah, and a lot of times doctors overprescribe.
Yes.
Or what if you have, we see this a lot of times, in fact, I'm thinking about a case where our social work team was called out because she was really having severe financial problems and some other things. Well, she was trying to keep something like 28 or 30 prescriptions open because she had different doctors, and she hadn't really communicated to all of her doctors what all of her other doctors were in. I know computers are getting more sophisticated now, and pharmacies are getting more sophisticated, so that's a little bit easier to track. But it may be that the older adult client didn't think to tell their cardiologist what their podiatrist just gave them, because they're completely unrelated in that person's head. But when they swallow it at the same time, they're a human test tube. It's all going to mix together and do something. So here this woman was trying to keep all these prescriptions open, and she had like 3 sleepers and 2 anti-anxiety medications. She really wasn't trying to abuse. She was trying to follow directions. She was trying to be a good little patient. But the communication was not effective enough, and she was really suffering because of it. So that may be something too. If you say the doctor has me on so many medications, is somebody facilitating that conversation? And it may be that they need that many, but it may be that there's some overprescribing. I need to have a glass of wine to sleep. What is that really indicating? I run out of medication before the prescription time is over. It could be that they're confused and taking it wrong. It could be that they're taking it because it said 1 every 4 hours or as needed. I needed 3. But these are just things that you might hear from a client that you just may want to investigate a little bit more. It's not an automatic sign of a problem, but you may just want to pay attention to it. The other thing that you may notice, like with the running out of medication before, they may not say that, but if you start noticing they're really getting anxious when they're starting to run out of pills, they're counting them. Now, how many more do I have? I've only have 4 left. There might be an anxiety related to it because that relationship is being jeopardized. So you might see it like that too. Okay. So just some things to think about. This is not just a character issue. This isn't really about willpower or being a good person. Even when the individual appears defensive, he's likely to be very ashamed of his behavior. Remember all that stuff we talked about right at the beginning about shame and the guilt that they may feel. So they may handle it by getting upset and telling you to go away. What you've really touched on is that shame. You'd all know this. Judging or moralizing can cause increased withdrawal from you. Often family problems or other stressors might contribute to the individual's desire to numb feelings, and that's where you start to develop as you work with a social worker and start to understand what the family dynamics are there. This is real important. Creating a safe, supportive, understanding rapport will help facilitate disclosure. This isn't.
What if they tell you, between me and you?
You won't tell my social worker, will you?
Right. Well, I'm going to tell you something, but don't tell anybody. And they tell you something that you feel you want to tell the social worker, puts you in a bad position.
It does.
That you want to help them, yet you don't want to, lose the trust.
Thoughts on that at all?
I'm a social work student, so I know from my classes and from things that with the confidentiality, I know, but if they're doing that and they're hurting themselves, then that's something you have to report automatically,
And that's sort of our mandate, is that
Okay.
you understand that they feel comfortable with you and trust you, which you are so pleased that they do, but you are
But
here really
I
to
see there's a
report.
problem.
Right. If there's something that they're telling you that it's harming them, you must report it. That's just how it goes.
From
Okay.
themselves or others.
Or others, that's correct.
Okay.
And it gets a little more complicated because they may be telling you something that they really don't believe is harmful to themselves. You know, and you know
Well,
that
they probably
it is.
don't think it's harmful, of
Exactly.
course, yeah.
Exactly. Or, you know, in a different situation, you might even be able to make a case for it not being harmful. But now you're carrying this. And,
Right.
and I think most of our clients too, and help me with this other, but I think most of our clients are also educated about confidentiality, at least at the beginning, and that they know, that they've been told.
Because this is explained when they first work with the social worker.
Okay.
The social worker will basically make that statement to them that, you know, if we hear something that it sounds harmful to you or someone else, we have to report it, you know, like to Adult Protective Services. So that's already explained usually when they're
Beforehand.
assessed initially by the social worker in any of our programs.
Okay.
And that really ties into these last two, which is you don't need to or can't fix the situation alone.
Okay.
It's not, it's first of all, it's bigger than you. None of us could
It's
do it
not
alone.
our
And it's
position.
certainly not your role. And assisting the individual to connect with resources is essential. That's probably the greatest gift. And you may be in a unique position to develop some trust and to encourage that, because maybe the social worker is involved with the family differently, or is working on a court case, or they just don't feel the same kind of freedom. You know, you may be in a really unique position to sort of facilitate the disclosure. And to think about, you know, I know you all you probably do this intuitively or had training too, but that idea of asking the open-ended questions, the things they can't just answer with yes or no. You know, well, tell me about how often you like to have a glass of wine. Is a lot different than do you drink every day? You know,
Right.
Or, you know, or tell me about how you remember to take your pills. You know, is again a lot different than do you take your pills on time every day. You know, so just thinking about how you're wording that. Okay, we've already talked about this, the adding in the family. Just a couple words about the family. Families might also have a tendency to be very secretive because of the same feeling of shame. So you can also let them know it's safe to talk to you about this stuff.
And
Same.
then,
Okay.
I was saying that I think that they're more secretive too, because then I'm like, well, we don't have a problem.
Right. There's really that almost align, even if there's a lot of internal turbulence, sometimes there's that aligning together against the world to keep the secret. You know, or the family's been keeping the secret for so long, it's just what they do. And the closer the community, you know, sometimes they're worried that people in the community will find out, or people at their shul will find out, or people in their, you know, their kids' school or their grandkids' school, or, you know, so, okay. Yeah, and this is, they'll encounter other members of their community. Okay. So when you identify a need, consult and make the referral. It's really your role there. Okay. And then there's just, we'll wrap up here, but there's just on your PowerPoint, there's a bunch of statistics too about older adults and substance use issues. So, any other comments, thoughts, or questions? If we are available, if you have questions or
And we have this-
concerns, you have that
we have
on your
this-
Yeah, it's in the
PowerPoint.
PowerPoint.
Call me
Oh,
anytime.
right here.
Do you think if one of our members here is in a client's home and they see bottles of alcohol, should they inquire about it or not even bring it up? Or should they say something about what they're seeing?
It's a great question. I would suggest, and again, it's all about building rapport, and as you get to know your client better, you'll know what your safety is. But let's play with that a little bit. Okay, when you see alcohol, what does that mean? Does that mean a bottle of cooking sherry on the shelf above the stove? Does that mean the bottle of Absolute that's under the sink next to the Windex? You know, does that mean
That would
the
be
half-finished glass? Does that mean the half-finished glass on the nightstand or behind the toilet? You know, I mean, you know, what does it look like? Something. I mean, you know, if they've got a can of Bud in the fridge, it's a different picture than if the trash is overfilling and that's all that's coming out of it. You know, so I think, you know, at some point, but chances are, and I'm just going to throw this out there, but you see the bottle of cooking sherry on the back shelf above the stove, you're probably not even going to think about it. So if you have that question, should I ask about this? You know, my guess would be, why don't you? You know, it's not, you're not going to damage the client by just having a discussion with the social worker about whether you should think about it. And your role is not to be a detective, but nor is it to, you know, ignore what is right there. So I think, yeah, I would always err on the side of let's explore it a little bit more than not explore it.
How do you cook? What seasoning do you put in the cooking? And if they say sherry, then that's what it's in the back of the cabinet for.
And if you feel like you need to explore that a little bit more, then, you know, you certainly could, you know. But I think, you know, I think again though, to really, you know, trust, I mean, you've got some good training, you've got some good intuition, you clearly are invested in caring enough you're here. You know, so I think to trust that thing that says, this doesn't seem quite right somehow.
I go with my gut feeling a lot.
But again, that doesn't mean you have to do anything about it right then. It means you can take that gut feeling and then seek supervision. And I think that's really what we're talking about, is take that gut feeling and go seek supervision. Does that answer your question, Heather?
Yes, thank you, thank you.
Any other comments, thoughts, or questions? Okay, thank you all for your input.
Well, thank you.
Thank you, Linda. Always a pleasure. I always learn something new.
Thank you. Thank you for including me.
Yes,
And the numbers are right there in case you have questions in the future.
and
Thank
it's
you.
on the PowerPoint.
They're very
On the
good.
back.
Okay, very good. Thank you again.
Oh.